Hello and welcome back to Pareto Education's YouTube channel. This is the Pareto Education webinar series for pharmacy first conditions, and this lecture will be focusing on shingles. We do have the other conditions as part of pharmacy first on our website as well on YouTube channel, so please do check those out as well. Quick introduction to myself. My name is Kamil Khan. I'm a physician associate working in secondary care and as one of the founders of Pareto Education, delivering high quality educational resources to the multidisciplinary team, including physician associates, ACPs, nurses, paramedics, and of course pharmacists, which will be the main focus of today's lecture. Pareto Education is a clinical education company founded on delivering high quality education resources in a contemporary way for the modern clinician. So we try and develop that foundational knowledge, and you'll find us on a range of social media outlets, webinars such as today, live workshops, university outreach, and also seminars as well. Please do follow our social media handles. You can see the variety of them here. We are available on YouTube such as today, TikTok, Facebook, Instagram, and do follow our QR code for our WhatsApp group as well. A lot of information shared via that. A key introduction into today's lecture. So we'll talk about some general principles, clinical features of shingles, red flags and complications, some risk factors, what antivirals you should be considering for your patient, and some safety netting as well. So that's the crux of today's lecture. For pharmacy first, there's some inclusion and exclusion criteria for each condition, and for these patients the inclusion criteria is any adult over the age of 18 with suspected shingles, and pregnant individuals are excluded as well. Any patient that does not fit within this inclusion and exclusion criteria should be sent to their general practitioner. So what is shingles? Shingles is the herpes zoster virus, which is a viral infection, and it is considering of the infection of a particular nerve affecting the skin as it's served by a particular dermatome. It is generally caused by the reactivation of a latent varicella zoster virus, typically which in earlier childhood causes chickenpox, and this infection sort of reactivates in most cases many decades after the primary infection. So initially a patient may have chickenpox, and then many years down the line, and the typical shingles patient will be 60, 70 plus patient. When a chickenpox infection happens, the infection typically lies dormant in the dorsal ganglion, which I'll explain in a second, and can reactivate when any time the immune system is weakened. And unlike chickenpox, which occurs following the initial infection and causes a more generalized rash all over the body, shingles typically affects a single particular area around a particular dermatome. So patients will experience this intense itchy rash, burning sensation around a particular area rather than it affecting the entire body. Remember that patients with active shingles, especially if they're immunocompromised, can transmit this virus to young children or other people susceptible to chickenpox. However, there's not a case or evidence to suggest that shingles can be acquired from a person with chickenpox. So it can go from shingles to chickenpox, but chickenpox to shingles, that doesn't really happen in most cases. Here is the anatomy of dermatomes that I was mentioning earlier. As you can see, these are the areas of the skin where sensory distribution is distributed via a particular nerve. You can see different areas of the body are innervated by different nerve endings, and these originate from the spinal cord, of course. There are a total of 30 dermatomes. If a patient is affected by shingles, typically it only affects one left or right part of the body as well. So normally it does not cross the midline for the patient. And this is just an overview of the dorsal ganglion, which I was mentioning earlier, which typically is where the latent virus is before it's reactivated, causing issues within the skin mainly. The overall incidence rate of shingles is around 2 to 4 cases per 1,000 population, and of course this incidence rate rises in the more elderly population. In England and Wales there are around 50,000 cases every year, and most of those in the over age 70 patients, and 1 in 4 adults will experience shingles in their lifetime. Remember, shingles is not actually caught from anyone, it's actually a reactivation of the herpes zoster virus when typically immune system is weakened, and this typically of course happens as we age. Remember, as I mentioned earlier, a person affected by shingles can give someone chickenpox if they've never had it, but a patient with chickenpox can't give a patient shingles, if that makes sense. Also, shingles is infectious. A patient with shingles at the point of the first blister until they crust over, approximately 7 days, are infectious at that point of time. So there are some things that we can do to help our patients. Typically, it's the shingles vaccine, which helps protect against shingles. It's recommended for all adults aged 65, and then recommended again to 70 to 79, or for those patients with a severely compromised immune system. Depending on the type of vaccine you get for the patient, it'll either be 1 dose or 2 doses. So if you get the Shingrix, it's 2 doses. Zostavax is given as a single dose. Remember, the shingles vaccine doesn't help someone who's already got shingles or post-herpetic neuralgia, which I'll explain in a second. So typically how it manifests clinically is firstly the patient will start experiencing abnormal skin sensations around a particular area of the body. Typically this is like a burning type sensation, unusual. They won't describe it as pain as such, but tingling perhaps. Normally patients may experience headaches, photophobia, malaise, although less commonly a fever may also present in the prodromal phase before the rash actually presents itself. Within a few days or weeks, then the patient will start seeing this unilateral, meaning it won't cross the middle of the body. So I'll be affecting the left side or the right side, and it can affect any area of the body as well, as mentioned earlier, affecting a particular dermatome. And it starts with this vesicular or fluid-filled blister in that dermatomal distribution. In immunocompromised individuals, a rash involving multiple dermatomes may occur in some cases. And again, tingling, prickling or numbing of the skin and intense itching is a very, very common symptom. The rash typically does last between 2 to 4 weeks for most patients. So the typical progression of shingles. So firstly, there will be this burning, stabbing pain, which can be intermittent or constant. Then the rash will appear shortly after, may have some fever and headache-like symptoms. Then the shingles rash, the group of red spots on a pink background, which quickly develop into these fluid-filled blisters. And some of these blisters then start to burst. Some fill with blood or pus, and then slowly they dry and crust over. Usually the shingles rash does affect a clearly well-defined area of the body, either left or the right, and typically does not cross over from one side of the body to the next. So here is a quick diagram just to show potential distribution of shingles and how it manifests between the early stages and the late stages. Also some pictures to show shingles in different stages and on different skin tones. Feel free to pause the video to study these further. Following the rash, one of the main complications is something called post-hepatic neuralgia, or PHN, which can develop in more elderly patients. And this is pain after the rash has gone, and typically 90 days or more after the infection. So it typically lasts 3 to 6 months, but can last longer, and the severity of the pain may be constant, intermittent, or triggered by any stimulation. The severity of shingles, again, I was mentioning many times in this lecture, does increase with age, and can require hospitalization if the patient is developing significant pain-like symptoms. If affecting the eyes, studies have shown that ophthalmic zoster can occur in 10 to 20% of shingles cases, and these can cause long-term complications, including pain. The mortality rate of shingles is quite low. However, this is because patients have other comorbidities that may actually contribute to the mortality rather than shingles actually being the cause of death. So the main complications of shingles include paresis, which is weakness, facial palsy, and herpes zoster ophthalmicus, which involves the eye and associated dermatomes. And this can cause complications within the eye, including keratitis, corneal ulceration, conjunctivitis, rhinitis, optic neuritis, and glaucoma as well. In quite rare cases, you can have this reactivated virus disseminating into the lungs, the gut, the brain, and can lead to complications within these organs. This is unlikely in the most of your patients, but can occur in those severely immunocompromised patients. And pneumonia is typically the most common complication and cause of fatality. As I mentioned already, patients with active lesions, particularly if they are immunocompromised, can submit this varicella zoster virus to susceptible individuals to cause chickenpox. So, you should be careful in terms of telling your patient about how they are infectious to potentially younger patients or those that are also immunocompromised. And like I mentioned earlier, there is no evidence that shingles can be acquired from someone who has chickenpox. So serious complications, I've got to mention about meningitis. This is another rash that you may see in your clinic. You may consider, is this shingles, is this meningitis? With meningitis, a patient will complain of other significant symptoms. Of course, they will have the rash, but they will also have neck stiffness, and the skin will be mottled. Patient will be very unwell, potentially in themselves. They have a fever. And the main common test that we use for this is the glass test. If you press the glass on the rash, then it doesn't fade, and this can be a sign of meningococcal septicemia, which is very, very serious. And also encephalitis as well, where a patient has some change in their behavior, maybe some seizures, and these need hospital admission, both of these conditions. So if you suspect any of this, then patient should be straight to A&E. Complications typically will involve, if a patient is to get complications, if they're having facial shingles, then you can have facial nerve paralysis, also known as Ramsay-Hunt syndrome, is when a shingles outbreak occurs affecting one of the facial nerves. Ramsay-Hunt syndrome can also cause facial paralysis and hearing loss as well. Remember, it is caused by the, again, varicella zoster virus and can reactivate. So you want to get these patients prompt treatment. So if you suspect any patient with facial shingles, then these patients need more attention and they need antivirals and corticosteroids. And here is a typical demonstration of a patient with Ramsay-Hunt with facial paralysis. Another key complication that you should be aware of is shingles in the ophthalmic distribution, which is the Hutchinson sign. This is where there is reactivation of the dormant varicella zoster virus, which leads to this painful rash. But when this rash is present on the tip of the nose, this is called the Hutchinson sign. And this is when there's involvement of the nasal branch of the nasociliary nerve. This raises the concern of serious ophthalmic complications, which I mentioned earlier, including blindness. So for these patients, they must be seen by ophthalmologist immediately. So any patient with suspected shingles, this rash has traveled to the tip of the nose, should be seen by ophthalmologist immediately in the hospital. And these patients need to go straight to hospital. Here is a diagram of some patients with the Hutchinson sign and the ophthalmic distribution of shingles as well. So these are more concerning complications with shingles. Here is a slide that shows again what I've talked about already. Any patient with these sort of symptoms, you would highlight and get over to the hospital straight away, because these are more serious signs rather than your run-of-the-mill bond or shingles. Again, you should take a new score for your patients, take some observations, and if a patient is severely immunosuppressed or the rash is severe or widespread, consider sending them to A&E. What kind of immunosuppressed patients may you deal with? Patients on cancer therapy, chemo, any patient on methotrexate, patient has HIV, AIDS or CD4 count, particularly less than 200, any patient with a transplanted organ, any patient on biologics. If a patient is presenting to you and that you concerned that they have significant immunosuppression, then consider offering the treatment and call the patient's GP as well. The surgeon send an urgent task for the GP to review as well. If a patient is significantly unwell, get them over to A&E. Typically, shingles does resolve on its own within a few weeks, but oral antiviral treatment can help the rash clear sooner and reduce the risk of unpleasant side effects. So to shorten this outbreak, you need to give the antiviral drugs, which is acyclovir, within the first couple of days of the outbreak. So early diagnosis is very, very painful. Advise the patient also to take some rest, and over-the-counter painkillers and cool compresses are very useful for most patients. If a patient has any complications such as a bacterial infection, they may need antibiotics, and if it affects the eye or the Hutchinson sign, as I mentioned earlier, they will need specialist input for that. To prevent this syndrome of post-hepatic neuralgia, the best way to do it is to get the patient antiviral drug therapy as soon as possible. This is a quick flowchart to show how you should deal with your patients, depending on the time frame and how you're dealing with them, and their presentation as well. So you feel free to pause the video to review this. So the treatment as per BNF is acyclovir in the first instance. So adults 800 milligrams 5 times a day for 7 days. Valacyclovir if a patient is immunocompromised or there's a problem with adherence, because acyclovir is a lot of tablets. How to safety net your patient. Tell all patients if their symptoms deteriorate or they don't improve within 7 days, then they should see their general practitioner or the provider as appropriate. And these are some common self-care tips for your patients as well. So you can use paracetamol, NSAIDs, cocodamol, and once they've recovered, then you can consider them having the shingles vaccine as well. Other safety netting is high-risk patients should avoid skin contact with anyone with shingles until the blisters crust over, because any patient that is at risk of chickenpox can have that transmission from a patient with active shingles. And also advise the patients with counselling if they feel that they have shingles to seek help immediately. Patients may need to also take time off work until the blisters have dried and crusted over. And of course, bed rest is always a good idea for these patients. Here are some quick references for your records. And a case. So we've got a 57-year-old patient presenting with blisters, painful rash. The rash came on yesterday with a mild headache. It's exclusively on the right arm. What do you offer? So by just looking at the history and a brief look at the rash in the picture, we can see this is probably shingles. So we're going to offer acyclovir for this patient. 47-year-old patient presents with an itchy rash on her wrist. It started a week ago. It's not painful. It's redness and marks of itching. There's no blistering. What you'll advise? So if you look at the picture and the story, it doesn't really look like shingles, so it's unlikely shingles. So you refer this patient to the GP. So a patient comes with a rash on her neck, started 2 days ago. You give him oral acyclovir. What other information would you like to give? Patient can have the shingles vaccine once he's over the acute illness phase as well. So that's a brief presentation on shingles. I hope you learned something from that, enjoyed it, and take it into your clinical practice. Do check out Pareto Education CPD for any other CPD courses you may be interested in. And as a reminder, here are our social media handles for you to join if you're interested. Thank you for joining, and we'll see you in the next video.